Good morning. My name's Ian Fannon. I'm a director at Claremont, and welcome to our latest behaviour change briefing event. We're going to focus today on sharing with you the work we took to the European Social Marketing Conference in Thessaloniki. I think I'm pronouncing that correctly, which was just a couple of weeks ago. And given my face was plastered all over the marketing for this, I'm going to be your host for today. And Ben, our founder, who sat next to me, but I'm going to try my best not to look at him, Ben's our founder. He'll be taking a sort of supportive role today as my glamorous assistant, being the Q&A master later on in the session. So today you'll hear 4 short presentations over the next hour before we open up to a Q&A session and panel discussion for the last half hour. If you haven't already done so, please go now to the chat function and introduce yourself and where you're from. And with no further ado, though, I'll introduce our speakers. So I'm going to be kicking off the session. Given I went to Thessaloniki, I'll talk through the presentation I did on the first morning of the conference, and that will be focused on some work we did with NHS England and Improvement London region, looking at scoping a cancer screening campaign for London. And I'm really pleased to be joined by Joe Ruende. Give us a wave, Joe. Joe is from NHS England London region and is the screening and immunisation lead who we work with on that project. Joe will be joining us in the panel discussion at the end. So if you've got questions about that work, and in particular about what has happened recently and since we did the work, then Joe will be able to chip in on that later on. I'll be followed by my colleague Lucy Proudfoot, who will share a presentation about our work on Flex Appeal that Lucy presented at the conference. Flex Appeal is a campaign for better flexible working in the UK. And then we'll hear from Kate Sanger from Joe's Cervical Cancer Trust. Give us a wave, Kate, who will be presenting with my colleague Anna, who will be talking about the research and insight work we did with Joe's Trust to understand changing attitudes to cervical screening in the wake of the pandemic. And finally, then I'll give a very short wrap up of some other things I saw at the conference, some highlights and themes. I'll only be a 5-minute presentation, just pulling out a few things that struck me from other things we saw when I was there. It's worth just saying that this event is a slight departure from previous events we've done, where we've tried to orientate the presentations around a particular topic or theme. Obviously, the only common thread here is the conference. But even if you do have kind of a limited interest in specifically in cancer screening or in flexible working, we know that the work we're going to present to you will have transferable techniques, transferable approaches, and learnings that we think will be relevant to a broad audience. So please do stick with us. Please do ask speakers questions as we go as well. There is the Q&A function as well as the chat. If you have questions for any of us, please pop a question in there and we'll do our best to address as many of those as we can in the panel discussion at the end, ably led by Ben. But also some of our speakers may be able to directly answer your questions in that Q&A function as we go if they wish to. So please don't hold back. Okay, so I'm going to kick us off, and just bear with me a moment. So let me just share my screen and I'll walk you through the first presentation. Okay. That's not the right one. I'm having a little issue with my screen sharing. Just bear with me a moment. That's the correct one. Okay. All right, so let's get going. So yes, this is all about My trip to Thessaloniki, so I thought I'd best start with some evidence that I was there. As you can see, it was a real hardship, but I was willing to take one for the team and enjoy the hot weather, the beautiful seafront and the delicious Greek food. But I wasn't just there to sip ouzo by the beach. I did also pop along to the conference, and it was a really great event. Where people who are interested in social marketing, from practitioners like ourselves, agency side, in-house large organisations like Public Health Wales were there, and lots of academics as well, bringing their latest thinking to the conference. And it was great to be back in a room chatting to people, making new connections. But you're not here to see my holiday snaps, so I will waste no more time and get on with the first presentation. As I say, I presented this on the first morning of the conference, and it was all about starting upstream and scoping the requirements of a social marketing campaign. So I am sure many people joining this session will have worked on projects or campaigns where the objectives have been fuzzy or too broad, and the audiences might have been underdefined, and God forbid, there's also no doubt been occasions where people have worked on projects where the target audience has been defined as the general public. I know I have in the past, and it's something that sends a shiver down my spine these days. But what do you do when you're confronted with a really highly complex problem where it could be multiple objectives, multiple audiences, and multiple barriers and drivers and motivations behind those audiences, and then therefore, obviously, as a result, multiple kind of tactics you can take to try to reach them, and channels. So we are often clients come to us faced with this difficulty and don't really know where to begin and what process to follow. So I'm going to walk through an example of when presented with that kind of complex situation, how to narrow the scope of a campaign by identifying which aspects of the problem to focus on in order to achieve the greatest impact. And at the end, I'm also going to reflect on my top tips to what to think about when applying this to other campaigns. So let's transport back in time to a glorious moment before there was a pandemic. So if we look back at sort of 2019, there were other serious problems that weren't about COVID, and NHS England came to us wanting support to understand what approach they could take to improve screening rates in London. Coverage of bowel, breast and cervical screening in London was well below rates elsewhere in England, and below the achievable targets, or targets that were considered achievable by the NHS. And a commitment had been made by a board of stakeholders responsible for this issue in London to doing a social marketing campaign in 2020-21 to improve uptake, but it was really unclear where to focus. They didn't know which of the screening programs to focus on, which audiences to focus on within that, how much money might need to be spent in order to have impact against this issue, and all of the decisions that flowed from those things were not made. Really, the only thing that was very clear was there was going to need to be a desire to ensure that we were addressing within any campaign particularly low uptake audience groups. And so we were asked to undertake a really rapid options appraisal to determine the focus, and including giving options at different budget levels. And we had to do this work in under a month. Really quickly, just to elaborate on the problem, you can see here on this chart that in yellow is the London data, and for each of those programs, they were behind both England and that achievable target that had been set. And there were a number of reasons that were hypothesized for this, but we needed to look through the evidence in detail. So as well as having 3 different screening programs, each with their own different type of test, there is a different eligible audience for each of those, with obviously breast screening and cervical screening being eligible for women, bowel being eligible for both men and women, and different age groups for each of those. And then within that, then there were a number of low uptake groups as well. So lots of common low uptake groups across those screening programs. For example, people from lower socioeconomic backgrounds and people from ethnic minority backgrounds, but also some low uptake groups that were very specific to certain programs. For example, trans men or survivors of sexual violence in the case of cervical screening. So we took an approach to scoping this project that basically went through these 5 steps, and I'll walk you through those in turn. So we began with a call for evidence from the stakeholder group. We only had a month to do this work, and we knew we needed to keep the scope of what we were doing tight in itself. So we had to go out to a group of people and ask us to help us surface as rapidly as possible evidence that was relevant to this issue. So academic papers that they knew about, but also other campaigns that they had been involved in or had seen from others that they thought we could learn from. And we gathered that work in and compiled it into a dashboard that brought some consistency to the way that we analysed the information that was being brought to us. So looking at the objectives, the audiences, the different channels used, different methods, and as well as looking at what evidence there was for effectiveness, any limitations around evaluation, and if there was any indication as well of the sort of level of spend. And so we gathered that information to a dashboard, obviously also contributed our own knowledge and experience from work we'd done in the past. And things started to take shape, but there were still lots of gaps when we did this exercise. And so a really critical next step was that we also then had follow-up interviews with selected stakeholders to help understand some of the nuance behind information that had been shared with us, and also get opinion as well as hard evidence. What were people's thoughts on the challenge that was being faced, and what had they seen that hadn't worked in the past that they perhaps wouldn't have been willing to put in writing. And so those interviews really helped us get under the skin of the issue. And off the back of all of that work, we then went through a process of trying to assess the evidence for effectiveness of those different approaches that we saw, as well as analysing the barriers and drivers for the different audiences. I won't go into all the detail of what we did, but just to give you a flavour of it, we looked at about 25 campaigns, many of which were focused on single screening campaigns, like these examples from Public Health England and Cancer Research UK. But there was one example we found that did attempt to do this pan-cancer screening approach of a campaign that had a consistent tone of voice and actually had a TV ad as well, that addressed screening in of itself, and then had separate executions underneath that directed at different types of screening programs, and that was the campaign you see on the right here from the Scottish Government. And as well as looking at these bigger campaigns, we also did look at some local London campaigns that had, and some of which didn't have an advertising element at all, and relied more heavily on community engagement approaches to have impact. And we also looked at about 10 academic papers and reports, of which these are just a couple that were particularly important ones. And what we did when looking through these reports, some of these are very detailed papers. The Duffy reviews looked at, I think, around about 71 intervention studies. So we couldn't go through every line of that, but we did try to extract from these papers the elements and the learnings from them that were most relevant to social marketing. And in this case, the things that stood out was the importance of reminders, the importance of personalization, the importance of the GP and the community voice in anything we did. So I've just summarized there in 2 slides what amounted to about 2 weeks of fairly intensive work, but there were from all of that work some overarching barriers and drivers that were common to all of the screening programs. And I won't take a long time looking at this, but this was the main things that came out were that there was a barrier around fatalism that people had about cancer. And that could be counteracted to some extent by using hope and helping people to see that screening saves lives and that an early diagnosis can lead to a positive prognosis. There was real fear and stigma about the nature of the test, which was true for all of the programs to some extent, but particularly true for cervical screening. We see that a lot. And that could be counteracted to some extent by offering reassurance and practical advice on specifically what to expect before going for a screening. And in some cases, lack of access to a test was a barrier. And obviously that can be counteracted to some extent by ensuring people know where they can get support, help to book and to attend, and looking at people who've got specific additional needs. But also, those were the barriers and drivers that were common to all the programs. But it was really clear going back to this point about the different, many different audiences in the lower uptake groups, that segmentation was really vital here, and that any social marketing campaign on this issue really needed to understand that there's a whole range of different audiences that have different messages that will be needed to be communicated to them to help them to understand better the benefits and help overcome some of the barriers, and different messengers and channels that will be relevant to each of those. And so based on all of the evidence we looked at, and also based on our own experience of running social marketing campaigns, we gave an overall recommendation about the kind of structure that the campaign needed to take. And this really identified that there was this pyramid that involved a mixed methods approach. And at the foundation of this pyramid, the kind of essential ingredient for a screening social marketing campaign was a below the line element, and by below the line, we kind of mean healthcare professional, stakeholder and community engagement activity that really utilizes trusted networks to get messages to people, particularly those diverse audiences. And the combination of this foundation stage, but also this targeted direct marketing to non-responders, ideally using the GP voice as part of the messaging to them. Those were the elements of this pyramid that really drive response for a campaign on screening. And then ideally, if budget is available, that would be supported with an above the line campaign, which is where advertising can be used to drive awareness, understanding, and intention to act. And the combination of those mixed methods has a powerful effect. And so we proposed 3 options for how the NHS could go about this. And one was looking at that Scottish Government example of a pan-cancer approach, so broad unifying campaign that really heroed cancer screening as a lifesaver, and with a goal of trying to improve overall uptake across the programs. We were very clear though with this approach that if you were going to do this, it needed below that pan-cancer message, very specific tailored executions for each of the screening programs as well, and specific approaches to different audience groups who had particular messages and messengers and channels that would reach them. And so that would really require quite a significant budget to go down that route. Whereas option 2 was a cancer specific approach, so zooming in on one or maybe more, maybe 2 of the screening programs to really dial in on that and drive uptake amongst those specific programs. And clearly then the audiences would be specific to that programs, and the messages would follow from there. And then a third option was an even more targeted version of that, which we termed micro-targeting, where there would be basically a suite of very small campaigns, potentially not even involving an above-the-line advertising element, where there would be very specific audiences selected where there is low uptake, and the focus would be very, very zoomed in on trying to drive uptake amongst those groups. And off the back of that, we also looked at budget considerations. And just to be clear, these were not set by NHS, but these were hypothetical budget ranges that we put forward just to kind of flesh out what the range of options could look like, depending on what resources were available. And this really reinforced our view that really to consider option 1 of a pan-cancer approach would really require a budget at this sort of far right of around £2 million plus. Whereas if budget available was further to the left here, of the sort of 250 to 500,000 pound range, there would need to be point you more to either choosing a single option 2 campaign, so one of those single screening campaigns, or that sort of very micro-targeted approach. Whereas if it was ending up in the middle range, there was potential to consider running multiple linked campaigns under option 2, with a range of tailored executions underneath that. And so we took all of these recommendations and insights to a collaborative workshop with about 20 stakeholders, with various people from the NHS, charities, academics involved, and we really unpicked the kind of the benefits, the pros and cons of each of these approaches, and the opportunities and risks attached to each, and really also explored kind of what the best combination of options could be. And then we took those options and the thoughts of the stakeholders to the London Cancer Screening Uptake Improvement Board to make a final decision. And that decision, and this was back in sort of March of 2020 by this stage, was that if we were going to go forward and develop a campaign, it really ought to focus on this cancer-specific or micro-targeting end of the spectrum, partly because of the available resources, that it was felt there wasn't likely to be enough budget to make that pan-cancer campaign approach work, but also because there was a sense that there was a need to focus in on cervical and breast screening in the first instance. There was a new fit test introduced for bowel screening. It was felt that it was right to sort of allow that to embed before doing a social marketing campaign to drive uptake. But it was also reflected that there was potential with that cancer-specific approach to align with national campaigns that might be run on the issue. And then below that, there was also kind of a view that we could really zoom in on particular low uptake audiences, especially first-time invitees, and especially this particular group of women aged 50 to 64 who had were being invited for breast screening for the first time, but also had not necessarily had a recent cervical screening test. So that was defined as a sort of bullseye audience that we might be able to focus on. And so that decision was made, and there was a decision made to form a panel to go forward and then develop that campaign. But this was March 2020, and actually that proved to be my last face-to-face meeting for some time. I'm sure it was the case for others as well. We were actually in Wellington House at Public Health England's offices having this meeting, and quite a few of us in the room thinking, is this thing going to happen? And sure enough, obviously we went into lockdown. The cancer screening programs were paused for some time, and so the idea of doing a campaign clearly was shelved for a while. And then that was then revisited towards the end of that year, but obviously the context by then had completely changed. Not necessarily in a good way. I mean, there was a backlog that had built up for the screening programs. And there was some evidence, and Joe and Kate and Anna will talk a little bit about this in their presentation. There was evidence that for some audiences, the issue got worse, that COVID was proving an extra barrier to getting people to go for screening. And so it was clear there was a need for a social marketing campaign on this issue more than ever. But the national situation had changed, and national thinking was moving on this issue, and there were plans starting to be developed for really key national campaigns. And so that's what then happened. So if we fast forward to spring of this year, there was a national cervical screening campaign led by what is now OHID, and there was a London version of this, which you can see billboards and various other advertising channels were used in London to promote this. To be clear, Claremont weren't involved at this stage in this work, but I was really reassured when I heard from Jo, and she'll be able to elaborate on this, I'm sure, in a little while, that the bottom of our pyramid, the community engagement activity that we recommended, was a real priority, and Jo assures me that sort of the strategy work we did at the start to help them scope this really helped to inform this approach. So finally, what are my 5 top tips for scoping a campaign off the back of all this work? So first of all, I think it's really critical that you map your universe of potential objectives. You've got to be able to understand at the start what is known, what isn't, what's being decided already, and what's up for grabs before you can zoom in on, go through a process to zoom in on what's most important. And so it was really important we established at the outset in conversations with Joe that the low uptake groups that were relevant for each of the screening programs, it was really key that we're going to need to find, develop a campaign that had the potential to address those. Everything else, in terms of which screening program to focus on, objectives, audiences, the rest of that was, and budget, were all undecided. And on that budget point, it's really important to clarify the outer limits of the budget and the ambition for a project at the start, because that has a material impact on what you can do. And whilst Joe wasn't able to say to us in our early conversations exactly what amount of money might be able to be invested in this project, because there was a need for us to go through a process to inform some of that thinking, she was able to say that actually 7 figures isn't out of the question. It might be possible, and therefore we knew we had to show what could be achieved at that end of that spectrum, as well as making sure we had options at lower ranges. And then once you're in the process, so those are things to do before you start, but once you're into the process, clearly really important to take people with you. And we designed an approach that involved our stakeholders right from the start, in getting them their help to submit evidence, obviously doing the interviews we did with them, and running a workshop to get their contributions, so that when we went to the board for a final decision, we had a room of people who'd already been through a process with us and invested in it with us. And then connected to that, really important to dig below the surface, we found that the quality of the written evidence that was available to us when we did the sweep of evidence was really variable, particularly for the effectiveness of campaigns that had been run before. We could see there was good work that happened, but it wasn't always possible to really unpick why things had worked and what had gone wrong and why that was the case. But we were able to dig below that through the follow-up interviews that we did with stakeholders, and that really helped add a level of richness to our insight. And basically, yeah, the kind of my major point is avoid spreading too thin, because it can be really tempting when you're trying to plan a campaign where there could be multiple audiences, that audiences that need that you can see there's a need for a behavior change that could benefit them. It can be really tempting to try and keep your audiences broad and help everyone. But our advice would be that, particularly when budget is limited, you have to make decisions to narrow your scope to increase your impact. Because otherwise you're just diluting impact if you're attempting to spread yourself across a broad range of audience groups and achieve a multiple range of objectives. So avoiding spreading too thinly, really try and zoom in and force those difficult conversations, even when it might be that might involve conversations that could be a little bit tricky with colleagues. So those are our 5 top tips, and that's my presentation. I'll be happy to answer questions later on in the session. Please drop them into the Q&A now if you've got some, and I'll start to take a look. But thanks for listening. Okay, so I'm going to stop sharing, and we're going to move on to Lucy in a moment. So Lucy, if you can bring your camera back on. I'm just going to refer back to my other notes, excuse me. Yeah, so Lucy is going to talk about our work on Flex Appeal. Yeah, just a quick reminder, if you... we were warned. Apologies, we were warned when we arrived in here this morning that there was going to be a fire alarm at 10 o'clock, and that was that. So Lucy, yeah, fire away, and if you've got questions, again, for me or for Lucy, please drop them into the Q&A as we go.
Thank you, Ian. Good morning. I'm going to talk you through our work on the Flex Appeal campaign, our development of the Forever Flex report. This is an example really of how we adopted a very positive approach, and in doing so landed at some very practical solutions for our target audience. So just to cast your mind back to 2018. So I was on maternity leave at this stage. I just had my first baby, and I'd started avidly following this influencer on Instagram called Mother Pucker, or Anna Whitehouse, as she's also known, who'd set up this campaign called Flex Appeal in response to the way that she felt sort of forced out of the workforce because of having a baby. And her big thing is that flexible working isn't just for parents, it should be something for everyone. And I was following her brilliant work in the campaign while simultaneously hearing from various friends or other new parents of their situation where they were being told, you know, come back full time or don't come back at all. And I was getting really kind of cross on their behalf. And I wanted to join in Anna's fight. So cut to 2019, when I was back at work, getting great flexibility, I have to say, from Claremont, I contacted Anna and I explained Claremont's behaviour change offer and sort of said, you know, we'd like to support in some way. Could we work together? And so we had a few coffees and met up several times. And off the back of those meetings, we kind of sat down and looked at her strategy. And a big part of that was, who was she targeting? So there were, at that stage, there were two kind of key audiences. She had employees. So she was doing a lot of work trying to raise awareness around flexibility, raise confidence, and just offer support to people who needed that flexible working. And she was also doing a lot of public affairs work. So she was lobbying government, trying to change legislation around flexible working. But between us, we decided that the missing piece in her campaign puzzle was anything that targeted employers. So we set out, that was our initial thing when we started working with her. We said, let's have a go at creating something that we can target employers with. And initially we were doing this work on a pro bono basis, but we then went on to secure some funding from construction giant Sir Robert McAlpine, which might seem like a bit of an incongruous fit, but they're massive advocates of flexible working because they're trying to tackle the shockingly high rates of male suicide within the construction industry. And they feel that offering flexibility is a big part of that battle. So what were we even campaigning against? You know, what was the problem here? Well, again, back in 2019, pre-pandemic, this very important point, there was this gap between the number of people who needed and wanted flexible working, which was at around 87%. So that's the employees who needed that time, versus the number of employers who were actually offering flexible working. So at this stage, our kind of overarching ambition, if you like, was to set out on this journey of trying to reduce that gap. But what were we up against? So we knew, you know, there was no shortage of evidence to show why flexible working was good for employers. It's better for staff retention, better for healthier employees, happier staff, good for productivity. But yet time and time again, people's requests for flexible working were being rejected for some of these reasons that you can see outlined here. And these are all the kind of the problems, the kind of barriers, if you like. But we felt to some extent they were kind of slightly true but useless. And if you look a bit deeper, you can see that these are steeped in kind of fear and a lack of control. So you're really kind of getting into that emotional piece and starting to see that behind the employer is actually a person, and that's what we wanted to tap into. We knew that we needed to create something that was going to be far more human than the reams of toolkits and stats and facts that were already in existence about flexible working. So at this point, we took time, and I would say this is a really, really useful exercise to do before developing any campaign, to kind of stop and pause and think, what are our main do's and don'ts here? What do we really want to achieve and what do we want to avoid? To help sort of keep us on track before we went on to create the campaign. So we thought, knowing what we did about the employers' resistance, we wanted to go down the route of showing empathy and really supporting employers through that journey and helping them overcome some of that fear. We knew it absolutely wasn't about embarrassing or attacking employers in any way. You know, shame is not a useful tool for creating behaviour change. We also didn't want to create something that felt like a kind of cookie cutter, this is how you do flexible working, because obviously every employer is completely unique and has their own way of working. So instead, we wanted to set about kind of inspiring them and demonstrating, so showing, not telling, how some of that change could happen. And who better to help us do that than other employers? You know, other employers who had been able to say yes to people's flexible working requests, because we knew through working with Anna that there were a few of these kind of, you know, quite unique employers doing that. So we had seen this actually at I think it was the European Social Marketing Conference in 2019. Some colleagues had seen this being presented at the conference, and we were heavily inspired and borrowed a lot of the thinking behind this. I won't say it's completely part of the campaign, but it's very inspired by it. And it's the positive deviance theory, pioneered by Jerry and Monique Sternin, who were doing kind of cutting edge social change work across the globe. And they discovered that positive deviants are the people who, or groups of people who can go against the odds and overcome the obstacles. And so in their case, they're talking about things like childhood malnutrition in Vietnam. But here, it's very, very different issue. But the point is, it's about letting go of this notion that experts know best, and instead looking to the people who can find solutions that already exist in the system. So we were really inspired by that kind of much more positive approach, and felt that that was really in keeping with the guidelines that we set out on the previous slide. So we went in search of we then called them bright spots approach, again, inspired by a term used by the authors of a book called Switch. The bright spots, i.e. the kind of observable exceptions. So the people the employers in this case, who were offering flexible working despite the obstacles. And we wanted to go and listen to them and learn from them and kind of extract some of their solutions for how they'd been able to overcome the obstacles and share those with other employers as a way to inspire them. However, we started recruitment in 2019 and sort of rolling into early 2020, and something quite big happened. And, there was this global pandemic and everybody was forced to stay at home, which radically changed the way most employers worked overnight. And they all were having to kind of suddenly try out flexible working, which had been our initial goal, trying to get more employers to try out flexible working. So it was quite a lot of, we really had to look at this and think, gosh, what's going on? And just to borrow Mike Tyson's famous quote here, this is kind of to demonstrate our sentiment at the time. There was a lot of questioning about, well, gosh, do we even need to carry on doing this campaign? Because the vast majority of employers are now actually trying out flexible working of some extent. Do we even need to carry on? Well, yeah, we did actually, because we were looking at this more closely and we felt that there were a lot of risks attached to what was happening. The big one being that a lot of employers, although they were doing sort of some form of flexible working, had been what we would call accidental flex. So it was flex that had been kind of thrust upon them rather than a well thought through strategy with systems and support in place that would help make flexible working last. And another big problem that we kept coming across was that people were conflating flexible working with essentially what was forced remote working, whereas good, healthy, flexible working could be any number of these things and more. It's about choice. It's about working well between employee and employer with the time and hours, not just doing it from your spare room. So did we need to adopt a new approach? Well, not entirely, actually. I think the main thing that had to shift was our aim. So we moved away from getting employers to try flexible working and moved more towards encouraging employers to sustain flexible working in a healthy, positive way. So our overall approach remained the same. We still wanted to go out and learn from these bright spot employers, but fundamentally it needed to be employers who'd been doing flexible working since before the pandemic, so that we could learn from the longevity of how their experience. We went out and found 32 employers from around the country, so different sizes, different sectors, different geographical locations, but also varying levels of flex as well. What we didn't want to do was just find a bunch of people who had flex all perfect. We needed people on different stages of the journey, because what we really wanted to kind of pull out were the headaches, the challenges, the things they'd had to overcome. That was going to be far more useful than us just creating 30 positive case studies of how things were brilliant and how flexible working was great for them. So we spent time doing Zoom interviews, and we had, they were depth qual interviews. So we kind of, went with the flow to some extent, but we had these kind of pillars of conversation. And the main thing we wanted to hear were what were the benefits to you, but also what were the challenges, what sort of things did you have to overcome from other colleagues. And we were speaking to the real kind of pioneers within these organizations. So in some cases, they might have been well on board with it, but there might have been other people that were still quite behind in their journey. And then we'd ask them what advice would they give to other people in their situation who were hoping to install flexible working, and what were their hopes and dreams for the future. I'm just going to play you a short video clip from one of our employers, talking about what advice she would give to someone else.
My thing would be just don't be too nervous to change things. It would be just give it a go, and always, as long as you're really clear to the staff that you don't know if it's going to work, and maybe this won't work for our company setup, but I'd like you to be part of the journey with me to give it a go. And if it doesn't work and you're like, oh no, this really hasn't, given it a good 6 months or 3 months and it's not worked, then if you've been honest with staff to begin with that we're going to see how it goes, and then you're honest with them that this is why it hasn't worked, then I think that normally people are quite grown up and can be like, I can understand that. And then maybe they, even if they think it has worked, you could negotiate a midway point or something. But I would say my thing would be just give it a go.
And I picked her because so many of our employers said something along those lines, which is essentially just kind of pilot it out, just try it out, go for it. We also, because of the nature of the report, it being used in a kind of business context, included some quantitative data as well. And we ran a short survey amongst 1,400 employers, again, across a range of sectors and range of sizes, really just to kind of take a bit of a temperature check on where employers were at that particular time and how they'd adapted to the pandemic and how they were thinking that that was going to evolve over the next 5 years. And then we took all of the insights from the 32 interviews, we took the quantitative data and we distilled it all into this report called Forever Flex. And I'll just show you the content slide and you can go and look at the report in your own time, but we had 3 key sections. So the first one was called Where Are We Now?, which was essentially a temperature check. You know, what were employers saying about flexible working? What were they hoping to do over the next 5 years? The second chapter was what can we do? This is a summary really of the 3 key themes that came out of our 32 interviews. It's a kind of distillation of the collective wisdom and experience from the employers we'd spoken to who were doing flexible working well, overlaid with our own kind of behavioural insights. Essentially the building blocks for making change happen. So when can you make change was the kind of, we talked there about the opportunity to make change. How to understand behaviours and motivations behind the behaviour was a lot about control and trust and the fear there. And then the beyond education piece was the practical tips for implementing flexible working. So things like setting clear boundaries, reframing flex and the terminology around it, if that suits your business better. And then the third section is Employers Like You, which was again a collection of stories and snippets from our employers, just to really kind of bring in that human emotional piece so that other employers reading this could feel that they weren't alone, that they were able to sort of feel sort of emboldened, hopefully, by other people's struggles in implementing flexible working. So if I'll just very quickly show you some visuals to give you a flavour for what the report looks like. But if you want to look at it in your own time, then I will share the link on Twitter as well after this, but you can find it here. And then just to wrap up, I just wanted to sort of show you some of the, you know, the outputs of the report beyond the report itself and the kind of engagement Anna was able to get off the back of having the report. So you can see here very high levels of engagement across Instagram. To some extent, there are some limitations with our data capture, and that's really regrettable, just the way that it's not been trackable. But you can still see that it was able to, you know, we were sort of appealing to lots of different audiences. So we have one very useful resource in itself for employers, but it was able to cut across 3 different audiences. So via employers, so to reach employers, we used the report to launch a well-known event for organisations called Flexpo, where there were over 600 businesses. There was a partnership on LinkedIn as well. But then also relevant for consumers who wanted to kind of hear progress about the FlexPeel campaign. Anna was able to take this report onto Radio 4 and various different national news slots as well, and as well in her public affairs work, and she took it to the Law Commission where she was trying to legislate for change. So, you know, with that one report, we were able to kind of cut across a lot of channels. So the work is by no means exhausted, and we're currently looking at the next steps that we can take in increasing sustainable flex amongst employers. Thank you. If anyone's got any questions, do pop them in the box.
Thanks, Lucy. I have to say, every time I hear Lucy talk about that work, it makes me feel very proud. It's such an important issue that we care deeply about at Claremont. So yeah, thanks, Lucy, for walking us through what we did. Okay, now we're going to hear from Kate Sanger from Joe's Cervical Cancer Trust and my colleague Anna Granger. who will summarise the insights and recommendations from our work together, understanding attitudes and behaviours related to cervical screening in the wake of the pandemic. You've both got your cameras on. I think, Anna, you're going to share your screen, aren't you? So over to you.
Brilliant, thank you, Ian. So yeah, I'm just showing my screen now. Brilliant. Right, so there we go. So thank you very much, Ian. So yes, I'm Anna, a senior consultant at Claremont, and I'm joined by Kate Sanger, Head of Policy and Communications at Joe's Cervical Cancer Trust, to talk through this presentation. So thank you again, Kate, for joining us for this. So we're going to talk to you about a research project we conducted on behalf of Joe's Cervical Cancer Trust to help the charity to sort of better understand how COVID-19 was impacting on attitudes to cervical screening in England. Now, these findings were actually shared at the World Social Marketing Conference in the form of a poster. I think you probably need a cinema screen to be able to read this. So we're going to break it down into smaller chunks to talk you through it. But just before we start doing that, I'm just going to hand over to Kate, who's just going to give us a bit of background and context about why this piece of work was commissioned and why it needed to happen.
Yes, so this work started in sort of as soon as the pandemic hit in 2020. Our support services, like with many charities, went wild with people contacting unsure about what was happening regarding cervical screening, regarding follow-up test appointments and cancer services as well. It was the cervical screening based inquiries that we were getting tons and tons of, because the programme in England, while the national guidance was for screening to continue, lots of GP practices were providing a reduced service or pausing it entirely because of, well, the widely publicised issues that were around regarding COVID and accessing primary care. And also the feedback on our support services was real strong levels of anxiety, confusion. Is it happening? Is it not happening? What can I do? What should I do differently? Can I go to the GP? Am I safer to wait at home? So we knew we needed to do something. And we were working with NHS England at the time as well, sharing insight and information. We conducted a short survey looking at how health professionals felt, how screening worked at the practice, what interventions they were providing or they weren't providing, and sort of any confusions that existed there among professionals. And then we also reached out to Claremont to help us with this piece of work, looking at how women felt and how we could support the remobilisation of screening.
Thank you, Kate. So just to sort of give a quick overview of the objectives, it was essentially to better understand the attitudes towards cervical screening and really how perceptions of risk associated with COVID was affecting attendance, and also really to help to inform how messaging and communication and support services could be adapted for women affected by that as well. The target for this was, it was all women in England who were due for cervical screening in 2020, with a particular focus on women from a Black or South Asian ethnicity. So what did we do? Well, we actually had two phases of this work. We planned to have two phases because it was a very fast moving time and we wanted to be able to repeat what we were doing. However, we did actually end up adapting this as we went along. So the second phase was slightly different from the first. So in the first phase of the activity that took place in June 2020, we did an online survey of 2,000 women aged 25 to 64. That's the ages at which people are eligible for cervical screening. This was women of different demographics and different ethnicities living in different parts of England. We also did 2 online focus groups and also 45-minute depth interviews. And all of the participants for these, they were either due for cervical screening in 2020 or overdue for cervical screening. Some had a history of cell changes or HPV, and some of them were at an increased risk from COVID as well. So that was the first phase of the activity. The second phase of the activity, as I mentioned, originally we were planning to sort of replicate this work and see how it had changed sort of 3 months later. However, once we'd done this phase, we actually adapted it slightly just to give us an opportunity to dig a bit deeper and to understand a bit better some of the insights that we had gathered from the first phase of the activity. So in the second phase, we did another online survey. This time it was 1,000 women. However, 200 were specifically Black or Asian or South Asian women. We also did another 4 focus groups and another 12 interviews. However, all the participants for these focus groups or interviews were either Black or South Asian. There was a slightly younger cohort, so aged 25 to 44, and all of them again were due for cervical screening or overdue for cervical screening in 2020. Now, it is worth noting that there were some limitations of this kind of research that we were sort of very conscious of when we were analysing the data. So first of all, obviously, it was an incredibly rapidly changing time. It was a very uncertain situation. So opinions and views were changing very, very quickly. It's sort of hard to remember back now exactly what was happening then. But back in June 2020, when we did the first phase of the work, kids were only just going back into schools, non-essential shops were only just starting to reopen, and pubs and restaurants were still closed. So that was the kind of the world we were living in then. By September, the restrictions had lifted significantly. Most places were open. Obviously, masks and limits on group size were still in place. However, I think pretty much everyone was acutely aware that the second wave seemed to be lurking just around the corner. So people were aware that things were probably going to change again. There was, again, a lot of uncertainty around what was happening. So obviously we had to be mindful of how the specific time and context that we were talking to the women might be affecting how they were feeling and how anxious they might be feeling as well. We also noted that in the first phase, the sample size wasn't really large enough to break down the attitudes of non-white women into specific ethnicities. And this is why we boosted the number of Black and South Asian women in the second phase as well, just to try and dig a bit deeper into understanding how women from different ethnicities were feeling about the situation. So what did we find? So, first of all, from the survey we did, we noticed quite a big difference between the attitudes of white and non-white women in phase 1. As you can see on the screen, across a number of different questions, we noticed that non-white women were expressing greater anxiety and fear relating to COVID, and also less sense of trust that they'd be kept safe if they went to their GP as well. I think the final stat here is particularly telling. The question here is, I don't think it's safe to go at the moment. And obviously there's quite a marked difference here between non-white and white women. And as I mentioned, we sort of tried to address the sort of ethnicity issue a bit more in our second phase of work, which suggested that it was women from a South Asian background particularly who were feeling anxious about COVID at this time. We also investigated some of the barriers to attending screening. We asked women in the survey to list the 3 main reasons that were putting them off attending cervical screening. And what we found is the top 3 that come up here were the same pre-existing barriers that we were seeing before the pandemic, so fear and anxiety, concerns around pain or discomfort, and also a sort of sense of embarrassment as well. So these hadn't gone away, they hadn't been superseded by COVID in any way. However, what we did see is that COVID was an additional risk factor as well. So as well as these things that existed before, there was also this added dimension of people feeling concerned about COVID. And this wasn't just concerned about catching COVID itself, it was sort of a wider set of anxieties around this as well. People were concerned that they might be overwhelming the health service. They were concerned that they might have to get public transport to go to their appointment, and that would put them at risk. Or as Kate mentioned before, there was a lot of disparity between different GPs practices in terms of to what extent screening was being offered. So there was uncertainty around this, and there was concern that people wouldn't be able to get an appointment if it was for a non-urgent reason as well. So there were a number of different ways that COVID was adding an additional layer on top of these pre-existing barriers. And in particular, for people who are maybe hesitant about attending screening already, so those people who very much had a sense of fear or embarrassment or were concerned about pain and discomfort, but who previously may have been persuaded to go, the benefits may have tipped them over in favour of going. They had this risk or concern about coronavirus layered on the top as well, which was sort of tipping the balance for them away from going as well. So it was adding an additional layer to the complexity really, and an additional barrier that was preventing them from attending screening. So we used the insights that we gathered, this was particularly through the qualitative research we did, so our focus groups and our depth interviews, to start thinking about how we might be able to segment the audience as well. And we looked at this in terms of interest and trust. So interest really is how sort of ready and prepared they were to go for screening, and trust was really about how safe they were feeling about it. So the majority of women actually fitted in the top right quadrant here. So these were people who were still keen to attend. Actually, the pandemic hadn't made a difference for them at all. The bottom right quadrant shows women who actually were unlikely to go for screening, irrelevant of the pandemic happening. So they were people who were sort of, I think the pre-existing barriers were a big issue for them. several of them sort of actually said to them ourselves, to be honest, I think I'm using lockdown as an excuse. That's not the real reason why I'm not going. It sort of doesn't help, obviously, but that's not the real reason why I'm not going. In the bottom left-hand corner, we had a quadrant who were absolutely adamant and resolutely unwilling to go at that point in time. And the sort of things we were hearing from them was things like, until there's a vaccine, there's no way I'd go to an appointment like that. So, as I said, they were just resolutely unwilling to go. But particularly interestingly was the group in the top left-hand corner. So this was it was a minority, but it was a significant minority, a large minority, who were keen to go to their appointments. They did want to go, they saw the benefits, and they wanted to be going to their screening, but they were very fearful. They wanted to know exactly what was going to happen when they were there. They wanted to know things like how many people would be in the waiting room, how the room would be cleaned between appointments as well. So for these people in particular, COVID was a barrier that was standing in their way at this time. Something else that was interesting, actually, we noticed through the qualitative work is for women who had attended a medical setting for any reason whatsoever during the pandemic, but prior to this research taking place, they tended to have a bit less fear. They'd seen for themselves what it looked like, and I think that had helped to reassure them about the situation on the ground as well. So I'm now going to move on and actually talk about a little bit about some of our recommendations as well. So as I mentioned before, our second phase of research actually gave us an opportunity to interrogate some of the findings from the first phase a bit deeper. So we sort of changed our methodology slightly to give us the opportunity to do this and to help us to really better understand some of the things we'd started to uncover in the first phase. So one of the things we actually looked at was we asked some questions in our online survey to help us to try and quantify how large the different segments that I talked about on the previous screen were. So on the left-hand side of the screen at the moment, the sort of darker green segment, this is the group of people, which was around a third of people who were basically saying nothing will stop me going. These are the people who'd go to screening, whatever. So as far as we were concerned, that was great. That was brilliant. There was nothing sort of comms-wise we needed to do specifically to sort of shift them along in their decision-making. At the opposite end of the spectrum, in the red segment, were people who were resolutely unwilling. I think there was basically nothing that was going to change their opinion on this. They weren't going to go. So again, there was probably nothing comms-wise really that we could have done to shift some of these people. However, the group sort of towards the middle left, I should say, the lighter green and the yellow green were where we were really focusing our attention. So this again was around about 40%, sort of 30 to 40% of the total audience. These were people who were sort of generally willing to go, but they had some questions that needed answering. It was the questions I mentioned before about what can I expect when I get there? Will there be other people in the waiting room with me? Will the nurse doing the procedure, will she be wearing full PPE? It was questions like that they wanted to have answered before they'd pick up the phone and make the appointment. And there was also the people who were a bit hesitant. They sort of weren't prioritising it right now. They knew it was an important thing to do, but in the sort of the world we were living in, they didn't feel it was as important and other things at that time as well. But we felt these two, with the two audiences, that with the right information, the right messaging and the right communications tactics, they could be perhaps persuaded to attend. So this was our real focus that we thought needed to be targeted with comms activities. And so as we've seen in other presentations, this research really helped us sort of hone in and focus on who this audience needed to be and really help us to understand who the audience we needed to be focused on were and what the sort of anxieties that they were facing were as well. We also found actually through the second phase of the research that it was South Asian women who were particularly likely to fall into these categories. And again, this helped us in terms of recommending who we needed to be targeting with comms activity. Okay, and so moving on again, the qualitative research we did through the focus groups and the interviews, particularly in the second stage, this helped us to really see that the decision as to whether to attend screening or not, it often hangs in the balance with many unconscious influences really affecting the final outcome. So it's not just about sort of telling them to go, it's those unconscious things going on in the background as well. And we concluded that to sort of swing the balance back, so obviously back away from the reluctance to go, we needed to address both the conscious and the unconscious influences. So this included sort of straightforward, providing reassurance to people, explaining to them what the medical settings were going to be like, telling them about the strict protocols that were in place and how patients were being kept safe at this time, giving them detailed information about what to expect in a GP surgery during the pandemic, as well as the benefits of why screening is so important. But it also included behavioural principles like the importance of social norming and personalisation and the messenger effects, really to help ensure that messages were shared with these hesitant audiences and that they were reinforced by trusted voices, so voices such as GPs and also community leaders. Particularly for women in the South Asian audience, it was really important that these positive messages came from within their community. So the messenger effect in particular was really, really important for them. So that's sort of in a nutshell what the recommendations were for this project. We then shared these recommendations with Cervical Cancer Trust and NHS England, other stakeholders as well. Some of these findings were also actually published in the media around that time as well. They were also obviously sort of used in other ways as well. So I'm just going to hand back to Kate for a minute or two just to tell us a bit more about how this research was used afterwards.
Yeah, I think pretty much just elaborating on what Anna said, that it gave us, I think especially for us, it was during the pandemic, resources were stretched, and so we had to be really targeted with what we were doing and where our time was spent. And the same with when we presented this back to NHS England as well, there was that sense of we can't do everything. So this really helped us to do that. So we did things like we prioritised working with the BBC Asian Network, and we worked with them on an hour segment, sharing stories, tips, reassuring information, and it turned into it was a real discussion, a discussion piece, which was great to sort of speak to one of the communities which this research found was much less likely to go during the pandemic. It really helped us to shape our messaging. So we developed a whole range of different blogs and films, things like sample takers walking us through some of the measures, safety measures that patients might expect, colposcopists talking about what to expect now, GPs sort of showing what parking spaces would be like, really basic stuff that seems so weird now thinking about it, but stuff that at the time we were just getting so many people saying, I don't understand about having to wait outside my GP practice. And we shared this really widely with stakeholders across the NHS and wider, and also put in our COVID information hub, which, like many other charities, we developed a really fast-paced bit of information content that was focused on the pandemic. One of the other things was we did a lot of work with health professionals and sample takers, and we were able to develop lots of tips on how to communicate and support with patients. And again, it was simple things such as communicating the fact that screening is available, because patients didn't know necessarily that screening was available, that they could go, they should go, and also that when their appointments were less available, that was causing a real confusion. So we were saying it's important to tell patients that, because that's what they want to know. They want to know that information, explaining measures to keep them safe, what to expect, being really detailed, and also reassuring patients that the test itself is exactly the same, because again, that was something that came through quite strongly as patients thinking things were different. Little things as well. I think some of the things that came through with the different high risk groups, again, it was really useful in terms of that targeted approach. And again, it helped to inform our awareness weeks and campaigns. We had an awareness week that followed about a month after this research finished, and that really helped us give a focus to that when it was really difficult to work out what was an appropriate awareness campaign to do at that point in the pandemic, because it was such a quick moving scenario. And I think for us, one of the best bits of this research was being able to do those two different segments, because like Anna said, things were changing all the time, how people felt, the NHS landscape and recommendations, guidance was changing all the time. So it was really great to be able to do that, to compare the changing attitudes and the things that hadn't changed as well, and people who just hadn't changed how they felt in that sort of period. And they, again, as Anna said, were some of those ones who we could develop that messaging to be able to kind of tip them over the line. And it provided lots of content for talking to the media as well, which was great, because obviously lots of people read the media, and that's when we got a lot more people coming to our support services as a result, and that's fantastic. And all the information is still relevant now. I think that's the thing as well. Not all of it, but we still talk about some of this research. It still gets used. It's still helpful with informing some interventions or some pieces of work, even though it's not super relevant, but we're still living in a COVID-y space. So I think the longevity of it has been great.
That's great. Thank you very much, Kate. So that brings us to the end of our presentation. So thank you for listening, and please do ask any questions and we'll be happy to answer those. And hand you back to Ian. Thank you.
Thanks, Anna. And thanks, Kate, in particular for joining us to talk about the project today. Joe's Trust does absolutely brilliant work, and so real privilege to have been asked to support you with that work. Okay, a quick reminder, if you have got any questions for Anna or Kate or Lucy, or for me or Joe Wende from NHS England's London region about the scope and work I presented at the start, then please pop them in the Q&A. And we'll be coming to the panel discussion shortly. Before we do that, I've got one final presentation, which is a much shorter one about the other things we saw at the conference. I'm just going to pull out 3 quick themes and then we'll get into the discussion. So bear with me a moment whilst I share my screen. Oops, excuse me. No, that's the wrong one. Got this problem of having 2 presentations set up ready to go, is I am sharing the wrong one. Okay, it keeps pulling up the wrong presentation. Bear with me a moment. Just going to cancel the other one. There we go. Okay. So yeah, this is going to be rapid fire. So I'm going to share 3 quick themes. Theme 1: marketing is social, and social isn't just for good causes. So this chap here on the right is brand strategist Peter Economides. I knew I was going to stumble over that pronunciation. He's based in Greece, and he was the keynote speaker on day 1 of the conference, and he kicked off with what I think was intended to be quite a provocative statement that marketing is social, and he kind of went on to make the point that big brands like Starbucks, for example, have been doing marketing that's inherently social marketing for some time, building communities, telling stories, deepening interactions through everything they do, and he argued that these brands are getting people talking and influencing behaviours on a greater scale than most public sector and not-for-profit sector social marketing campaigns ever achieve, and that the concept of social marketing as a domain that's restricted to good causes in the public and not-for-profit sectors is a fallacy. And this would sort of sparked an interesting debate within the conference over the 2 days, with, I'd say, perhaps the purists in the room feeling possibly a little bit threatened by the idea that big brands might already have their sort of tanks on the social marketing lawn, and that they are that they have a right and actually have the right interests and motives for doing this kind of work. While I would say, for my money, the more enlightened folk within the room recognise the potential for government and charities and public sector to collaborate more with purpose-led brands to use their voice and their reach and their influence to drive change. So that was a really interesting theme. Theme 2, co-design almost always improves outcomes. We're a big fan of co-design at Claremont. When designing campaigns or interventions, our default position is to try to use a co-design approach, working alongside the end audience, unless there's a good reason why not. And I would say that there weren't that many presentations I saw that featured a co-design element, but the ones that did reinforced my view that co-design almost always improves outcomes. The first example I'm going to show is this one, Bristol Girls Can, which is a sort of spin-off from Sport England's This Girl Can, which was presented by Dr. Fiona Spotswood from the University of Bristol on the right here. She described this kind of struggle that many women face fitting physical activity into their week after having children, and how their life is often constructed around other people's needs, not their own, and how this is especially true for women from lower socioeconomic backgrounds. And so her team identified that the motivation and opportunity to exercise frequently isn't enough to overcome the fundamental capability barriers of a lack of time, energy, and support. But many of these women that they spoke to were using children's centres every day, and that those children's centres were one of the few institutions in their lives that they really trusted. And so Fiona's team began the Small Steps project, working with a group of children's centre users in Bristol to redesign the service to incorporate more opportunities for mums to get active whilst they were there, using their childcare and stay and play type facilities. So they adapted stay and play, for example, to build in physical activity for the parents in a sort of gentle, welcoming way. And Fiona talked at the conference about how, when the research insights that were underpinned this approach were shared with this group of mums, half the room was basically in tears, because they felt heard for the first time. They felt like someone had taken the time to understand how they felt about this issue, and then they also felt more invested in finding a way forward as a result of being involved in this co-design approach. And I have to say, it's a pattern we see a lot when co-design is used. You can a highly motivated group with lived experience really can help you move mountains. And then the second example on co-design front I wanted to share is creating happiness heroes. This was a lovely project presented by Sarah Cork from the University of Brighton, and please forgive the fuzziness of the slide on the right. It's the best picture I could get from a distance where I sat in the room. This was a project that was aimed at reframing children's mental health in a positive way, and equipping parents with evidence-based tools to build resilience and healthy minds among 4 to 7-year-olds. And it involved working with parents and trusted voices in the school system to design a happiness heroes club with members given a big box of happiness to use at home. And it was packed with activities they could do with their family. And there was strong evidence that kind of this positive framing of the issue really worked, and there were reported changes amongst the group that it was tested amongst in the children's confidence levels and reduced anxiety. But what really stood out for me was that Sarah's goal was to sort of roll this program out through further co-design in other parts of the country. They're looking to move on to Birmingham next, I believe, recognizing though that the exact product and execution of this might change if they go through further co-design and support those local stakeholders in new areas to adopt the model to their own needs. And she wasn't precious about that. It was important that the principles held true, the evidence base behind it held true, but the exact execution could change. And it was also designed to be sponsorable by local or national companies to enable the products to be sustainable and reach as wide an audience group as possible. So that was really lovely. And then the final theme I wanted to touch on is that systems thinking beats individual behaviour change. And bear with me on the next couple of slides. I am not going to attempt to talk these through in any detail, but this, I can't do justice to the talk that was given on, there's a keynote presentation on day 2 by Professor Christine Donegan, you can see here from NUI Galway. She had, I would say, some of the more brain-frazzling slides at the conference on systems thinking, of which this was one and this was another. And I'm not going to attempt to explain the slides, but there was deep insight behind what she was saying, which is essentially that systems that drive behaviours are often incredibly complex within society. And we can't afford to oversimplify just because it's convenient for us as marketeers. And she argued that attempts to segment and profile audiences and then target people with tailored messaging in the way I was describing in my first presentation to try to encourage behaviour change as individuals, when they fail, it's often because they overlook the way that people's behaviour is really influenced heavily by the systems around them. And so to tackle society's biggest challenges, she argued, we need to attempt to map these formal and informal networks of exchanges, a kind of macro level, a micro level, and what she described in between as a meso level, to get under the skin of where influence really exists on any given behaviour. And there were some applied examples after this presentation shared at the conference of projects that had attempted to use this systems thinking approach. But if I'm honest, I didn't think that they were very good, or at least the ones I saw, I didn't think were very good. There may well have been other ones I missed. And so I won't waste time touching on those, but my reflection really was that whilst there is some really good thinking going on by some of the academics in this space, I think there's a lot more room for improvement for those of us on the practitioner side to get better at applying this sort of thinking in the real world for the right kinds of problems. So with no further ado, I'm going to hand over now to Ben, who is going to walk us through the panel discussion and the Q&A. So we've got some good questions coming in, Ben.
Yes, we have. There's one that's possibly straight for you, actually. You might want to do through the Q&A tab from an anonymous attendee. What was missing from the conference, Ian? What would you like to have seen more of? I'm going to leave that one for you. Type that one out, actually. I mean, I'm going to just do this verbally.
Okay.
The first question with Joe. So we're going to go.
I'm here, Ben. Can you hear me? Are you on mute, Ben?
Can you hear me okay, Joe?
Yes, I can hear you.
Yeah, sorry about that. My trusty assistant put me on mute. Clients know that they can't communicate everything to everyone, but they still come under pressure to include more audiences, more messages, more everything. How can campaign planners help clients say no more often? How can we help clients make your campaigns more targeted and focused? Is that a reasonable question, Joe? What do you think?
I think it's a reasonable question, because I think this is the conundrum that we placed at Claremont Store back in 2019. We want to do everything. We want to target everyone to improve the uptake of our cancer screening programs. But clearly, we didn't have a budget that would stretch to pursue the pan-cancer option that Ian spoke to. But also, I think if we take an inequalities lens to it, we know that we should invest more in those that have greater need. And we know that uptake, if I'm speaking in the context of cancer screening or any public health program, that uptake varies between groups. So it makes sense from an inequalities point of view that we should invest where there is greater need. And we know that audiences vary. And again, thank you again to Claremont for the strategy and the framework that they provided for our campaigns, because I think in my response to you, I'm reflecting what you advised us, or what Claremont advised us, that looking at our different low uptake groups, there are different barriers and enablers, and there are various ways in tackling those barriers or amplifying those enablers. So obviously you can't have a single message or a single route or a single strategy that tackles, that speaks to every single audience that's eligible for your screening program. But I do think that in that framework, in terms of, let's say, an above the line campaign, you can have a campaign that speaks to everybody, but actually you need to invest more, the more targeted investment into those that have the lowest uptake.
Thanks, Joe. That is a neat bridge, actually, from some of the things that you've said over to Kate. You mentioned, Joe, about focusing on where the lowest uptake is, and using a lens of health inequalities to see where to target most. And Kate, I wanted to ask you, as a smaller charity, how do you decide on what to prioritise? I mean, we can see clearly that charities like Joe's Cervical Cancer Trust are doing more and more and more with health inequalities. Is that the way to achieve a focus? Is that the way to home in on something and be able to say no to other things? What do you think, Kate?
I guess it goes to it. I guess on the flip side, if you keep on doing things, national things across the board and the same old thing, then you're going to widen the inequalities, because you're going to keep not reaching the same people. We can run social media campaigns, we can do things in the media quite, I say easily, I don't mean easy as in we get front pages and things like that, but I just mean it's you can develop those quite quickly and roll them out. And again, you're only reaching those people who use Instagram, who use Twitter, and all those kind of things. So I think the inequality side for us is really important. And again, there's a white paper coming out soon around health inequalities in England. There's a real push to make sure that we are trying to reduce those inequalities. But I think for us, it's the research side as well is really important, because we need to make sure that we're speaking. We know what the barriers are, what the challenges are, what the perceptions are among those communities before we start doing the work, before we start walking into communities and doing things. And that's sort of a lot of the work our outreach teams do. For example, our engagement outreach teams do a lot of community work where some of these inequalities are highest. But yeah, and I think when we're not a big team, we don't have big budgets, so we do need to pick and choose a little. But I think it's also looking and seeing what other people are doing, because if everyone's focusing on the same inequality, we've all got to make sure that different people are focusing on different things. There's different interventions, different campaigns to make sure everyone's getting the same opportunity.
Thank you, Kate. I'll just play back a few things that I took from that, so I've got that right. It's that yes, health inequality is a big way of focusing, but also a gap analysis to look at where other people have already done stuff and where you could slot into context. I would like to add as well, building on what you said, that we often have to put into the equation where we can have the most impact. You may have a huge health inequality, you may have a huge gap in it, but there may actually just be still too difficult for a campaigner or a communications approach to actually have an effect. It might need a different type of intervention. And that's how we sort of, we set our crosshairs on different aims. Thank you, Kate. I'm going to go to Lucy for something a bit different. Lucy, you gave us the Flex Appeal campaign. The Flex Appeal, the whole issue of flexible working was completely sideswiped by a Black Swan event, the pandemic. I mean, a lot of the other talks, including, have mentioned what happened here. It came out of nowhere. It had a massive bearing on things. Could you walk us through how you adapted, how you pivoted to this situation? What did you learn from this Black Swan event?
Yeah, of course. I mean, yeah, it certainly sort of threw us off track quite a lot. And there was a genuine moment where we thought, do we even need to continue? Because, at that point, our broad aim, albeit quite a large aim, was to just get more employers to try out flexible working. And literally overnight that was happening. So I think the first thing that we did was to kind of pause and just to try and hold our nerve a little bit. And just, of course, at this point, no one knew how long anything was going to last and how it was going to pan out. So pause, take stock, monitor. So we were reading everything that came out in the news. We were monitoring amongst kind of friendly employers, if you like. So obviously Anna herself had been campaigning, and FlexPeal is an established campaign. It's been running for 5 years. So through those 5 years, she had people that she could kind of go to and say, what's happening here? And we got a bit of a sense from them that they were starting to feel the risks that were involved here, the risks that, all their hard work that they'd done in implementing Good Flex were being undermined by what was going on. And we paused and monitored. We spoke to employers. That would be the first thing. The way we changed and adapted our approach was, we had to move away from just trying to get more employers to try out flexible working. But what we had to try and do was create something that would prevent this reverting back to the old way of working. So we really focused our efforts on teasing out information from other employers that would help these employers in a state of accidental flex to kind of sustain the flexible working in a healthy way. And if you read the report in that third section, you'll see that what we really kind of made, so we adapted our questioning, we adapted our line of questioning in those depth interviews so that we could hear from people how they overcame challenges and made practical solutions to make flexible working a long-term thing. So you heard from the lady in my video, things like just trying it out. Well, that was to some extent not really relevant, but it is relevant if you think about just trying it out in different ways. So what she wouldn't necessarily have been talking about get your colleagues to work from home. She might have been talking about a completely different type of flexible working. So there are some practical tips in our report that employers could use. The other big change we made was to include the quant in the survey, and I think to see the pandemic as an opportunity, because we had this sudden opportunity, if we just carried on with work, to actually go out and speak to a load of employers who were living this live change. And that was a really, you know, as a researcher's point of view, a really great and fantastic opportunity. So we were able to kind of find out what the impact of this forced flexible working was having on them, sort of kind of live in the field, which was again very useful for the report. So I think those are the main things, really: pause and monitor, and then sort of change the approach to our questioning, but also, you know, just don't be afraid to seek the opportunities where those big changes come along.
Thanks, Lucy. I hope we never have a Black Swan event quite like that one again, but I think we can all be sure that there will be some kind of things to sideswipe us, but thanks for that. We've got time for one last cheeky question. I'm going to ask this one of Ian, please. Ian, you swanned off to Greece for the European Social Marketing Conference. Was it worth it? Would you recommend going to other people? And any tips on making it worthwhile and value for money?
Yeah, I'd say on balance it was. I mean, it was an expense, obviously, going off to Greece. And as much as I joked about it earlier, I really didn't see very much of Thessaloniki. It was mostly inside a conference centre. It was worth it mainly for the connections I was able to make, more than the content, I would say. But there was, what we find when we go to these events is that if we walk away with 2 or 3 really insightful presentations that make us think differently, it's worth it. And we've seen that when we went to the last one at Edinburgh. We saw that again in Greece. But the value is particularly strong if we're also presenting, because it gives us opportunities to talk to people a bit about what we do, and helps with that forging connections. So I would recommend, if people are thinking of going, think about what you could present, think about what work you're doing. That it doesn't necessarily need to be finished. If you've done some interesting insight work, like the work we did with Joe's Trust, that hasn't necessarily led to an interventional campaign, that is valid. But if you've also done a fully fledged campaign that's measured outcomes, then that's even better. And I'd highly recommend it. There's one coming up in Brighton in September, which we're planning to go along to. Deadline for submitting to that is July the 15th, so you've got to get your skates on if you want to submit something. Yeah, we'll be going along. Brighton's a bit easier to get to than Greece, so yeah, I definitely encourage people to do it. For us, it's more important to do those kind of things than, for example, award entries, which, you know, back in the day we might have spent time crafting award entries. We don't tend to do that these days. It's more important for us to kind of measure ourselves against the threshold of presenting at these kind of conferences.
Thanks, Ian. I think we're on time, so we'll wrap it up.
Yes, thank you. And thanks for everyone for contributing questions. And if we didn't get a chance to answer a question, I can see there's 1 or 2 in the Q&A that we didn't come back to. We will try to do that directly to individuals after the session. Thank you to everyone for their contributions today, and obviously thank you as well to my glamorous assistant Ben, and thank you everyone for listening. If you've enjoyed the event, please sign up to Clare Mail on the Claremont website, or follow us on Twitter and LinkedIn. I think the details to where you can find those links are in the chat. We aim to send a Clare Mail every 1 to 2 months, and this is always the first place you'll hear about our events, so please do sign up. And if you've got any comments or feedback about today's event, please also email us at hello@claremont.org.uk. That's it. We hope to see you again soon, but goodbye for now. Take care.